survey in 2020, Liverpool CCG was in one of the top 10 CCG employers in the country, with high levels of staff satisfaction, and also that staff would recommend Liverpool CCG as a good place to work. Our vision, alongside our other health and care partners in the city, is to have a healthier, happier and fairer city, and set out in our One Liverpool strategy, which I would commend people to read if they've got time. Impact of COVID in Liverpool, I think it goes without saying it has been an incredibly difficult year. Certainly from last April, we couldn't have envisaged the impact that this pandemic was going to have on our society, our businesses, our communities, our families, friends and colleagues. It has widened our health inequalities, and that has had some devastating impacts on life expectancy in the city and an increase in suicide. It's important at the start of our AGM that we acknowledge, like the rest of the country, the number of people that have sadly died as a consequence of contracting COVID in our communities. We pay our respects to all those, both staff, family, friends and colleagues who have unfortunately lost their lives in the past year. It's personally a sad loss that we had to announce the death of Professor Donald O'Donoghue, who died after contracting the virus, who'd contributed to both NHS Liverpool's board for many years, but he was also a colleague of mine from many years past, from my days in Salford Health Authority in the early 90s. We've also lost one of our GP colleagues, Dr. Thomas, that was included in my Chief Officer report last month. And also Richard, who was a very fond and warm chair of the Health Scrutiny Committee, if scrutiny can never be warm and friendly. But he made life very fair and honest for us all in the city. So our condolences to go to family and colleagues, both past and present. I think I must also say a huge thank you to all our staff. The amount of hard work, determination, sorrow and commitment that they've shown to serving the needs of our population throughout the last 12 months has been outstanding. And that's people in our hospital setting, in our GP primary care setting, our community staff, our mental health staff, social workers and those in our care sector, in our care homes and residential homes. A huge thank you to all of you for the contribution that you've made and continue to make. It's been an incredibly challenging year for everyone, but I know we all work hard to keep serving the population and keeping people well across Liverpool. I think the pandemic certainly tested our resolve and our strength of partnership. We have a good, strong health partnership in Liverpool. The amount of mutual aid between organisations that was provided, you know, we had adults in our paediatric intensive care units at times during the last 12 months, unprecedented in my career of 36 years in the NHS. We've worked very closely with our providers and even contributed to CCG staff being redeployed to the front line where necessary. We worked together to share resources, whether that was PPE, beds, staff, just general requests. Everything was considered and nothing was too much trouble. There was a real team spirit and it helped us pull through in a really difficult time. We've also worked across Cheshire and Merseyside with that alliance, particularly for cancer patients, and we maintained as many cancer services as we could throughout the pandemic. Back in November, I got a phone call one Sunday night from the chief exec in the local authority to say we were going to be a pilot site in Liverpool for population testing for COVID. The conversation went very much of, and we'll have to have it up and running for Friday, but we will have army support. Brigadier Joe Fossey has become a friend of Liverpool in the spirit and the partnership working and the contribution that the military made to helping us get up and running to provide population testing, which was a national testing facility and pilot huge contribution to the testing of lateral flow tests for ensuring that we could get our communities and our city back up and running. Over 10,000 people were tested in Liverpool from April to July 2021, and continue to offer support to some of our other public servants in the police, fire service, paramedics and other NHS staff. We also saw a massive increase in the ability for us to be able to support people remotely at home. Telehealth support we were provided with £850,000 to really expand rapidly the telehealth service that we offered already in Liverpool. It was already European and internationally renowned for the number of patients that we were supporting at home. But between April 20 and March 21, over 6,400 patients will be able to be monitored by the telehealth service remotely, ensuring that any exacerbation of healthcare needs were met as soon as possible. We also supported the rollout of telehealth across Cheshire and Merseyside. Further 1,300 patients was provided with oximetry, which is also remotely monitored, and it's a service that's provided at home, avoiding over 1,000 hospital admissions, beds that were needed for people who were really suffering from COVID. Services have performed, I think you would say, reasonably well across Liverpool. We have obviously been impacted unavoidably in the backlog that we now have for elective surgery. We have to now free up capacity to ensure that we continue to support those who are unfortunately admitted with COVID, and numbers have steadily increased but have kind of plateaued now. But even so, we are still not out of this pandemic, and it still continues to give us concern as we progress. Our 4-hour standard target for A&E was better than national average, but failed the national target overall. More work has been done to ensure our A&E units were able to cope in a safe way during COVID, and were actually offered on an appointment basis throughout the pandemic. And 111 First commenced in November 2020 to help identify patients that required A&E and offer an appointment for those that needed it. Referral to treatment times, our 18-week target, if you will, we missed that, and performance is in line with the national picture and showing signs of recovery. But we know for many people who are on those waiting lists, it cannot come fast enough. We will do what we can to ensure that people are treated as quickly as they possibly could, and we do ask that they bear with us in a difficult time when our capacity is so badly constrained. 2-week rule for cancer. One of the targets that we really strongly tried to maintain, obviously, for all our patients in Liverpool that require a 2-week referral. We met the standard between February and October. We did fail it again to meet it in November. Referral rates are being closely monitored, and we've shown continued improvement since. We started our vaccination programme in Liverpool back in December. We brought welcome news for the first COVID vaccine had been received regulatory approval, and I think we all breathed a sigh of relief that we thought then that the pandemic could be managed more appropriately and we could get back to some form of normality. We've worked closely, obviously, with our GPs and our primary care networks and our local hospitals and the council to roll out vaccinations to our population. Again, demonstration of significant partnership working across the system and mutual aid to ensure that those that are eligible for vaccination can do so as soon as possible. We've had a real focus on making primary care-led vaccination a key feature of the approach they wanted to take to vaccination to get to the heart of our communities. We didn't decide on a mass vaccination centre like some, but we really wanted to ensure that it was accessible to as many people as possible in order for people to access and take up vaccination. Targeted engagement, working alongside our council colleagues, our vaccine bus, and I think we've got a new colleague called Neil who drives the bus for us, who's been a real asset, and a thank you to Neil specifically for his enthusiasm and his encouragement to people to jump on board and get a vaccination. It has supported our approach to ensuring that as many people as possible can be vaccinated, especially those who are not known to us in the community, who are maybe not registered with a GP or might find it difficult to access services in a traditional way. We've delivered pop-up clinics in communities and local mosques, working with local community and faith groups to promote vaccination and really help people understand what the vaccination is and stem some of the fears. Our local vaccination programme has delivered over 327,000 first dose vaccines and over 296,000 second dose. That's 70% of our Liverpool's eligible population, and we continue to encourage people to come forward for vaccination in order to help us manage this pandemic and keep our system and our society moving. So moving forward with the NHS, and I think it's worth saying during this time we also saw the publication of the ambition from the NHS to move towards statutory basis for integrated care systems. This also caused us some anxiety. Obviously, as an organisation, it's quite clear from that time that CCGs were likely to be abolished, and as we know, the bill is currently going through Parliament. But our focus on Liverpool and our place of Liverpool and our One Liverpool strategy is our roadmap for how in Liverpool we will work together to continue to try to strive to improve health, our outcomes and reduce inequalities. The vaccination programme will continue to be a focus for us, particularly as we enter into another winter alongside our flu campaign and the booster. So other priorities, mental health particularly. We know that mental health problems during the pandemic have been a significant challenge. We continue to invest as a CCG in our mental health services, both for children and adults. In April 2020, we set up also mental health crisis lines for both adults and children and young people, 12 months ahead of schedule. An adult line date has received over 30,000 calls across our North Mersey area. An additional over £6 million has been invested by the CCG during 2021 in a wide range of mental health services for all age. The investment has included things such as crisis care, child and adolescent mental health services, psychosis intervention, dementia, support for victims of sexual violence, bereavement through suicide, and perinatal care. We continue to engage our communities in the services and the commissioning decisions that we make. Some examples of how we've engaged our population over the last year were in autumn 2020, the CCG asked people in Liverpool to share their experiences of accessing healthcare during the pandemic. Over 1,300 people provided us with feedback, helping to inform us in terms of how we continue to reinstate our services. Other activities have included language and interpretation services to develop new and enhanced services for patients. A new specification was developed in partnership with local trusts for patients who require an interpreter. A procurement process was undertaken and a new universal service is now being embedded across our local providers. We work with local Liverpool University Hospitals Trust to engage with patients who've had to use spinal services to design a single model for spinal care for Cheshire and Mersey. This feedback also helped to shape and redesign the service to meet more effectively people with those needs. So the future of the CCG, as mentioned, we're now considering the new bill that's going through Parliament, major NHS organisation changes on the horizon, and with the disestablishment of CCGs on the 31st of March, following the DHC's white paper. Under these plans, Liverpool CCG will be replaced by the Integrated Care System for Cheshire and Merseyside and a Cheshire and Merseyside Health and Care Partnership. We will work with the partnership between now and then to ensure that our functions transfer seamlessly, and we will provide governing body with assurance that that is being managed. We obviously remain committed to our vision our One Liverpool strategy and the partners and all the residents that live in the Liverpool system to make sure that we can continue to provide really good quality care across the system. Thank you.
Thanks. So I think we're moving over to Mark now. Hi, Mark.
Thanks, Fiona. Good afternoon, everyone. Again, just by way of introduction, my name is Mark Bakewell. I'm the Chief Finance and Contracting Officer for Liverpool CCG. So just by way of quick recap on our accounts and our responsibilities. So we have a requirement as a CCG to meet our statutory financial duties and to meet any targets as set by NHS England. So for the 2021 financial year, that was a break-even position, and that enabled the retention of our brought forward surplus position of just under £22 million. But our goal for the year was to break even against the resources allocated to us. We were also required to meet our requirements around the mental health investment standard, and Jan has already described some of the investments that we've made having created that fund. One of the most important aspects, and obviously clearly what we're here today, is that we have to then prepare and submit a set of annual accounts and an annual report in compliance with the national guidance, and particularly from an accounts point of view, that they meet the IFRS and indeed the Department of Health accounting manual. And again, we'll come to that shortly. We also obviously have to try and make sure that we spend our money wisely, commissioning those high quality and effective services that Jan has described in the previous update. So we had a total of around £1.3 billion flow into Liverpool CCG during the year, of which, as host of some of the Cheshire and Merseyside system funding of just over 300 million, again, we were the sort of the host vehicle for that to happen. So just under £1 billion spent on Liverpool Health Services, and again, there'll be a short film coming up just to help provide a bit more detail. And then last but not least, an assessment of our value for money, so how we've spent our resources through the lens of economic, efficient and effective use of our resources in that sense. So I am pleased to say that despite the challenges of COVID, we did meet a lot of that, but I think it's worth just reflecting very briefly on the impact of COVID and the essence of that within our financial accounts. It's fair to say that 2021 was a very different year for all the reasons that Jan has described, but certainly from a finance perspective, it led to a different set of financial arrangements. We had a different envelope to work within. That was adjusted by the national team, and all of our sort of payment systems were pretty much turned upside down. And just to say a big thank you to the whole of the CCG, and particularly finance and contracting team, for the way that they've adapted to that, enabling lots of things to happen very quickly, but also always ensuring that we have a strong sense of governance and grip on that expenditure. So, big thank you to the team. We also received a number of other non-recurrent funding streams to help support some of those COVID pressures, particularly around funding into primary care, and equally what is known as the hospital discharge scheme, again, ensuring that patients were able to be discharged in a timely and effective manner. In total, we received an additional £23.4 million for the year. As you can see, the vast majority of that flowed into the hospital discharge programme, just around £17 million. But we did see some real innovation and opportunities to support some of the good work that was already underway. So specifically, the telehealth programme received a significant amount of money to expand that across the wider Cheshire and Merseyside system. And again, we saw the benefits of that in terms of our performance during that period. In terms of our key financial duties, again, a successful year. So there are 4 key duties that the CCG has to meet every year. As you can see from the table, I'm pleased to say that the CCG met all of those. We achieved a very small surplus, so £11,000 on 1.3 billion for the financial year. And also we did not exceed our running cost allowance, which again is another small target within our operating processes. So just under £9.7 million we spent on our running costs for the year, which was below our target. So from a financial perspective, a really good result. Obviously, the next part of the process then is that we submit those accounts, and I'm pleased to say again, we received a very positive audit opinion on the financial year. We received an unqualified audit opinion, which demonstrates that we have presented a true and fair view of the organisation's activities for the financial year. We received a positive value for money conclusion, so that again is on the basis of those 3 E's in a traditional sense, and a very positive report for the CCG's activities given the circumstances. We are due to have an audit on our mental health investment standard in Q3 of this year, but again, all the indications are that will show positive intent, and that we've met the standard around increasing our investments of around 5.3% more than our programme growth for that particular year. And last but not least, that our positive audit opinion has sort of helped us to inform our NHS England a view of our processes for this year, and again a favourable opinion during that period. So all in all, a really positive result. That is the end of my slides. Just like to again thank everyone involved in the production and the the pain that we go through at the early parts of the year to get that through, given the challenging timelines and again the remote working that we've had. But fantastic achievement for everyone, and thank you for listening.
Thank you very much, Mark. So we are now going to try and hopefully run our second animation, which outlines a bit more of the spending. And then I'm going to switch the order around slightly. So just to give advance warning to Dr. Gaynor and Rachel Avanitis that I'm going to put you up next, because I know you've got clinical commitments that you need to get back to. So once this animation's finished, we'll come to you then. Thanks. So I'm going to hand over now to Ed and Rachel to tell us about the Healthy Lung programme.
So thanks very much for giving me the time to talk about the Liverpool Healthy Lung programme. So as you can see there, I'm Ed Gaynor, I'm a GP, but up until April, I was also the Liverpool CCG lead for cancer. So what I'm planning to do, just very briefly, is to give you some background to the Liverpool Healthy Lung programme, for those of you who are not familiar with it, explain what we did, and also what the independent evaluation found, and also what we're planning to do next. So I'm afraid this is a bit of a whistle-stop tour. I think what's important to understand is why Liverpool CCG decides to invest in this programme. And at that time, that was a very brave decision because there were very few parts of the country that were doing this. And I think the figures in front of you provide ample explanation as to why the Liverpool CCG felt this was a priority area. We had the highest rates of lung cancer, or one of the highest rates of lung cancer nationally. And this was particularly focused on deprived communities. So Liverpool Healthy Lung was a 4-year programme, and it started in 2016. And its aims were to assess and promote lung health in a specific age group of 58 to 75-year-olds. It was to identify those who might have lung problems, such as chronic bronchitis or lung cancer. And a questionnaire was used to identify those at high risk of lung cancer, or higher risk of lung cancer, should I say. And they were then offered a low-dose CT. So that was basically the programme. And these really are the results from that programme. So you can see the headlines figures. I think probably the bit that I want to bring your attention to is of the CTs that were done, 20% had an abnormality that needed following up. So some more figures. So 126 cancers were diagnosed. I think the most crucial bit of that is that 75% of those cancers that were diagnosed were early stages, stages 1 and 2. So normally when lung cancer presents, it's usually stage 3 and 4. And the difficulty with that is there's very little curative treatment that can be offered. There's lots of other treatment that can be offered. While if it presents in stage 1 and 2, there are both surgery and radiology type treatments available. So that is really important. And also the figures show that we picked up lots of chronic lung disease, and that there was a huge satisfaction rate from the patients that were involved in the programme. So one of the important parts of the whole programme was to tackle inequalities. And I think the figures here sort of suggest that we have actually managed to do that, which was part of the reason for focusing on lung cancer, because that is definitely a higher incidence in our deprived communities. So a bit about what next. So there is now a national programme which is called Targeted Lung Health Checks. It's very similar, but there are some key differences, and it's across locally more than Liverpool CCG, so Knowsley and Halton are involved, and it's nationally funded, so the CCG are no longer having to scrape together the pennies to pay, the crucial factor is so the reason that we're part of the Targeted Lung Health Check is because of our involvement in the Liverpool Healthy Lung programme. I think if we hadn't done that, one of the constants of being involved is that we were invited to be part of the targeted lung health checks, which is a great success for Liverpool. So there are some key differences between the two programmes, and they're shown here. But I think the key bit is that the larger population, this will cover a larger population and will have the opportunity to take advantage of the programme. And a higher proportion of that population will end up being offered a CT scan, which means that we will diagnose early lung cancer in more patients. So both of those are very positive. So in terms of the new programme, this is where we're up to. So you can see that lots has happened and we're up to speed. So it's currently screening in Liverpool and due to move to Knowsley on the 24th of November. And this programme is a 3 to 4 year programme as we travel around the 3 CCGs. So just a few thoughts really about what this programme has actually meant to Liverpool. Liverpool CCG, as I said before, made a very brave decision to back this programme in 2018 and it invested a considerable amount of money. And I think the figures here have shown that that was a good decision. The delivery required huge commitment across the local health economy, who pulled together in a fantastic way, basically working their socks off. And that was both primary, secondary care and public health. The university were involved, and obviously a huge amount of support from the cancer team and the CCG. I think we have to bear in mind that we still have a huge amount of work to do. And therefore, that's why it's so important that we carry on the programme as part of the national programme. And I think probably the biggest challenge remains, as it was for the Liverpool Healthy Lung, and that is around recruitment. So I don't know whether you remember the first few slides, but we recruited about 40% of the target population, which is good, but still a little bit disappointing. I think that's the big challenge that we're trying to address in this particular programme. So that's, as I said at the beginning, a slight whistle-stop tour of what's been happening over the last 4-5 years. There is a very detailed evaluation report. And if you are interested in reading a bit more about what was achieved by the Liverpool Healthy Lung programme, then please request that from the CCG. So thank you very much for listening.
Well, thank you. And we've had that presentation at governing body as well, and or similar. And so I would reiterate the thanks to the team and well done on a great piece of work. Thank you. Okay, moving on then to our quality report with Jane. Over to you. I can see you're ready, Jane. Thank you.
Thank you, Chair. Just to introduce myself again, my name is Jane Lunt. I'm Director of Quality Outcomes and Improvement for Liverpool CCG. Next slide, please. Just going to talk you through some of the things we did and didn't do during the COVID pandemic. Just to remind ourselves that CCGs have a duty to support the continuous improvement of quality, particularly in our commissioned services, and that's all the services that we commission right through from the large NHS trusts you'll all be familiar with to smaller organisations that are often in our voluntary community and faith sector. But how we did that in 2021 looked very different to normal. I know I'm stating the obvious when I talk about the COVID pandemic impacting greatly on the NHS, and we've talked about the impact of that in Liverpool in previous presentations, but NHS services had to adapt quickly in response, and what I'm going to talk through in the next few slides is some of the ways in which we did that. Next slide, please. So in response to the pandemic, we already work within a health and social care partnership within Liverpool, and Jan, our chief officer, spoke about the work that we do with our partners, particularly around the One Liverpool plan. But what the pandemic did bring was an even wider health and social care partnership approach, and we made very many new partners during that time, and a number of those have already been referenced. And so some of the things we did in the early months of the pandemic, if you think back and remember that immediate response, you'll remember that the news was constantly referring to the challenges around COVID and how infectious it was and how we all needed PPE. So one of the very early things that we did that was part of a national drive was to support care homes in terms of infection prevention and control, training staff and supporting them with PPE. And Jan's already spoken about the work that we did around mass testing, but we also distributed a large amount of PPE during those first few months, whether that was to care homes or to GP practices, and sometimes to individual homes where some people with complex care were being cared for by their families with packages of care. And so we did whatever we could to get that PPE out to where it was needed. We've already spoken of the scaling up of the digital approach, supporting virtual assessments in all different aspects of healthcare delivery, and that was to reduce face-to-face consultations where we could, and where it was appropriate to do so, so that we only expose staff and patients to those face-to-face procedures where it was absolutely necessary. We also had a helpline, a phone line for colleagues across that health and social care partnership, but also for families where we provided clinical advice and support and guidance in relation to some workforce inquiries. And as I've already said, sometimes from patients and families, particularly in those early months when there were numbers of individuals in the community that were shielding, and we were supporting them in terms of access to the services that they required, because that would be very different during that time. Next slide, please. So we also did what we could as a CCG to help ensure the maximum number of staff on the front line. And in reference to what I said earlier about one of our main roles as a CCG around quality surveillance and quality improvement, what we did in those initial few months was we stood down a lot of our routine processes to allow staff the maximum time possible to address the demands of the pandemic. But when the timing was right and when it made sense to do so, we reinstated those processes. But what we did was we focused on key issues and challenges that would support the trusts in how they were addressing the pandemic. So we focused on their infection prevention and control measures, and what we tried to do was provide support and challenge so that they got that right. We also stood back up our management of incidents, including our regular review panels, and we've already spoken about the impact of COVID on waiting times, and I'll talk a little bit more later about that. We've supported the safe reinstatement of elective services and cancer services as referenced earlier. But one thing we did do as well was we made sure that any quality concerns or issues were reported through to the quality surveillance group. That's a group run across Cheshire and Mersey. It's led by NHS England, and what that does is it brings together all of the quality risks and concerns across Cheshire and Mersey for reporting up through the NHSE hierarchy. So we made sure that we were very clear in our reporting to that group during COVID. Next slide, please. We also established a clinical care home cell, and we work very closely with the local authority, with colleagues in adult social care, but also in public health. And what that was trying to do was establish support for care homes, recognising that in Liverpool we have a number of larger care homes who are part of a larger national infrastructure, but we still also have a number of homes that are run by charities or run by small businesses. And what we needed to do was develop support that worked across all of those. So we developed a capacity homes, and that was looking at the numbers of residents within there, so that we knew at any one time where vacancies were in care homes and which care homes were busier and may need more support. And what we also did was we made sure that as we discharged patients safely from hospital, we deployed appropriate clinical support into the homes to enable those patients to be received safely. One of the great benefits of the pandemic, and it seems a bit kind of bizarre to say that in terms of end of life, but our pathways of care around end of life did improve during the pandemic, and a lot of the learning we've kept. Some of the improvements we made very early on was about better access to medications for end of life, particularly for those patients within care homes, and those improvements have been sustained now. We also supported care homes in terms of staffing. So we supported a review of a workforce model for care homes and supported our local authority colleagues in forging relationships with agencies that supplied staff. And where we could, we sourced training from the NHS to support care home staff, because keeping those care homes staffed was absolutely vital for the care and support of the residents there. Next slide, please. In terms of safeguarding, some of the changes that took place, such as working from home, being schooled at home, meant that we were living in a very different way, and a number of individuals in the community had their support networks either changed radically or at times completely removed. In addition to that, the way that services were delivered meant that with the reduction of face-to-face contacts and some services being stopped and the staff redeployed in different ways, what it meant was that the eyes and ears of the NHS, because every NHS service or commission service has a role in terms of safeguarding, it meant that the eyes and ears on the most vulnerable in our communities were reduced. And so we had to think about how we could be sensitive to the changes that were going on and the risks that were out there in the community for some of our more vulnerable individuals. So we set up weekly conference calls to understand the impact of these service changes on the safeguarding of vulnerable children and adults. And the police, the local authority and the CCG maintain those conference calls for a significant period of time. And what we tried to do was use local intelligence, particularly from the police, because they weren't able to stand down their services during the pandemic, as you can imagine, and they were very much the barometer of what was going on. And what we did was we changed responses and we increased support across certain cohorts of the population where we felt that it was appropriate to do so. And particularly one of the issues that we did start work on during the pandemic, which we've maintained, is the work around those who are experiencing domestic abuse, and the pandemic particularly threw some challenges for all services around that. Next slide, please. In terms of the response to the pandemic, some things continued as usual. So, for example, CCGs have a responsibility for the commissioning of individual placements of care for patients with complex needs. That didn't change at all during the pandemic. What we also did, and reference has been made to this, is we implemented the Discharge to Assess guidance, which was essentially supporting the effective and safe discharge of patients from hospital. And we also managed the step down of the continuing healthcare framework and its subsequent reinstatement. Some of the work that we implemented in light of that change in guidance we've kept in place because it actually gives better outcomes for patients. We've referenced the work that we've done around the homeless individuals and how we've tried to support increasing GP registrations and access to services. And we've referenced the support that we've given to the delivery of the vaccination programme. What we've been doing in recent months as we've supported the post-COVID system recovery is that we have recognised that in terms of those growing elective waiting lists, that processes are needed to support the trusts in how they review those waiting lists and try and make sure that patients don't come to harm during that waiting process. And we've got what's called a harm review process that has been rolled out across Cheshire and Mersey based on what we put in place in Liverpool initially to support trusts in managing that. Next slide, please. Thank you. Thank you for listening. And I'd just like to say thank you to colleagues across the whole of the CCG in how we've come together to work in that wider health and social care partnership to support the response to the pandemic. As I've referenced, some of the work that we've undertaken has had benefit that is to be sustained, and it shows that sometimes some good can come out of adverse circumstances. Thank you.
Thank you very much, Jane. That's lovely. Okay, so we've reached the end of the presentations for today, and we're going to move on into our Q&A section. And apologies, we would much rather do a live Q&A because I think you get a much better quality of discussion going. But we can't do that over this in this setup. So we've got questions, and thank you to those of you who sent them in. It's a little bit clunky, but essentially what I'm going to do is I'm going to read the questions out and invite colleagues to answer them, and I'm going to answer some of them myself. So bear with me, I've got a few bits of paper because some of the questions are quite long. So the first topic of questions that we're going to cover is about GP access. So we had 3 questions in about GP access, which is not surprising really, given that it's a current very hot topic. So I'm just going to read the questions out. The first one was, when will GP surgeries be back to seeing patients face to face? And it goes on to express concern about the difficulty for older people or hearing impaired people to use telephone appointments. So that's the first one. The second one was, in view of the tsunami of criticism levelled at the obvious reluctance by GP services to return to pre-pandemic working and the upward pressure this lack of face-to-face consultations is having on A&E departments, what steps are the CCG taking to ensure that all GPs are returning to full working in their surgeries? And then the third one on this subject was, as 66% of GPs were working part-time hours before the pandemic, what percentage of those 66% have gone back to working full-time post-pandemic in order to help relieve the backlog of over 5 million patients waiting for treatment? So I've taken them all together because a lot of the answers all 3 questions. So we absolutely recognise that this is a major concern for members of the public, for patients, and it's attracting significant media attention at the moment. And we share, and the GP community shares, a lot of the concerns. However, I have to say that I have got very significant concern about the persistent negative and unjust media commentary that is associated with this issue. I have real concerns that this is damaging the relationship between patients and their practices and their GPs, that it may be worrying for some patients and putting them off seeking medical attention when they should be and could be receiving it. And thirdly, I know that this is having a serious negative impact on the health and well-being of our practice staff, and that is not good for patients either. So I will respond to some of the specific points in the question, but I wanted to start with some more sort of general remarks on it. And my first point is that I want to say thank you to all of the staff working in general practice and primary care in Liverpool at the moment. And I want them to know that myself and my colleagues in the CCG recognise how hard you are working. We know how much pressure you are under, and we know how utterly demoralising it feels at the moment to be working this hard while being subjected to such a torrent of negative media coverage and abuse at times. We know that verbal abuse and on occasion in the last week, physical abuse of GP staff is on the rise. And all the while receiving no support from our political leaders, who are in fact responsible for the current situation, because there is a crisis in primary care, but it is not the fault of our hardworking primary care teams. It's the results of years of underfunding that have led to a reduction in GP numbers while we have been promised an increase, but the actual number has gone down, at the same time as demand and complexity in the number of patients has gone up. The pandemic, which is also not the fault of the GPs and their staff, has just exacerbated an already overstretched system. So moving to address the very specific points in the questions. So we do understand why people are concerned about wanting to have a face-to-face appointment when it's needed, because if you speak to most GPs, they would rather be doing face-to-face. It's what we all went into the job to do. At the moment, about 57% of all contacts with GPs are happening face-to-face anyway, and that has gradually been going up as we've been tracking it throughout May, June and July. It's going up by 1 to 2% each month, and I think that will continue as hopefully the COVID situation improves. Telephone first is not a new concept, and many practices have been running telephone first even pre-pandemic. And the purpose of it is twofold. And at the moment, really importantly, one of those purposes is to keep people safe. We cannot have vulnerable patients sitting in very tiny waiting rooms being exposed to potential COVID infection, when we know that there are parts of our city that still have infection rates of over 400 per 100,000 population. And so those COVID rates are still high enough that the risk is justifies the use of telephone first. A GP practice who has to protect its staff as well, because if you lose 1 or 2 of your GPs, that can be 50% of your workforce if they all catch COVID at the same time, and then you would have no service to provide at all. The second point of telephone first is to help manage the huge increase in demand. And actually many patients find telephone much more convenient, and it frees up time for GPs and nurse practitioners and practice nurses, etc., to actually see more patients face to face. It's much slower to see patients face to face because of the donning and doffing PPE and the cleaning that's required. So if we went back to full face-to-face appointments, the overall number of available appointments would actually fall, which would make it even more difficult to see a GP. So we need the best of both, because we know that elderly patients who are hard of hearing, find telephone very difficult, and not everybody can manage online consultations. But I think if we, going forward, we will have a mixture of both, because if we get rid of the telephone and online access, we will get just as many complaints from people who do prefer that as an option. Just to address, so the question talked about a tsunami of criticism levelled at the obvious reluctance of GPs to return to pre-pandemic working. I would say yes, there is a tsunami of criticism, but as I've said before, I feel that this is completely unjust. And I cannot agree that there is an obvious reluctance to return to pre-pandemic working. I speak to GPs every day, and we would all love to get back to pre-pandemic ways of working. Because that's the way that we want to manage and interact with our patients. The increasing pressure in A&E is a reflection of demand across the whole system, not purely down to the pressures that are in primary care. And despite primary care currently offering more appointments now than we did 2 years ago, there are just not enough GPs to meet the demand to provide the service that we know people need this service, but there are not enough GPs to do it. The CCG is aware that there is variation between practices, and we're in close contact with practices to support them so where there is an issue with access, we're there to support and challenge the practices to make sure that they're doing everything possible that they can to maintain access for their patients. Where there is evidence that practices are not providing access and not doing everything they can, then we will work with them. We will be holding them to account to ensuring that they improve. And then the final point was about 66% of GPs working part-time, and when will they return to full-time? I think it's really important that we remember that GPs are human beings, and they are entitled to work part-time in the same way as any other professional is entitled to work part-time. Many of them will have young families. We might have elderly parents. We might have our own medical conditions that mean that we need to work part-time. And I would rather have a part-time GP in the practice than no GP at all. Many of my colleagues are choosing to work part-time now, as it is the only way that they can cope with the level of pressure and stress in the job. In my own practice, full-time partners work between 50 and 60 plus hours a week. So a part-time GP will very often be working between 35, 40 hours a week, equivalent to most people's full-time. And the 5 million backlog of people waiting for treatment will not be treated by GPs. These are people waiting for hospital treatment. And while they are waiting for that hospital treatment, it is their GP practices who are filling that gap. And that is another pressure on GP services that means it's more difficult to get appointments for new problems. So I would like to finish on a positive note, and that is to say that despite all of these pressures in primary care, the GP survey, the National GP Survey in July this year told us that 83% of people were experiencing a good experience of their GP service, which under the current circumstances, I think is very good. And I think GP practices are to be congratulated for how well they have managed throughout the pandemic. And so to any members of the public who are listening to this or maybe watching it afterwards, I would just ask that you be kind and patient and support your practice so that their staff are there for you, because they do want to help you. And if you need them to be there when you need them, then we need to support them now. And finally, thank you again to all of our practices for all their hard work. And I apologise, that was a bit of a long answer, but it felt really important to address that. So we'll move on to the second question, which I think Jan is going to answer, and that is, will there be more money invested in children's mental health services in the next financial year? Thanks, Jan.
I could bluntly answer that and say yes, but I'll give a more detailed answer because I think it's worth reflecting on the investment that the CCG has been making in mental health services over the past few years. What the money has gone into, we've invested in child and young people's community mental health services, increasing access rates and exceeding the national target by approximately 60% of an increase in access since 2015. We know it's not enough. Absolutely, we know it's not enough. but we will continue to make that investment. We've invested in children and young people's crisis services. This is a crisis service including a telephone helpline, mental health assessment and follow-up appointments, and A&E department liaison. Demand for calls over the last 12 months, we've actually received over 4,323 calls to that service. Children and young people support at the front end in our A&E departments is development of a community multidisciplinary service. It meets national targets and for routine and urgent referrals into that service. Alongside that, we've also invested in adult crisis services, a new mental health urgent care line put in place 12 months ago, which was ahead of our plan. That took over 30,000 calls last year. Early investment in crisis resolution and home treatment, and alternatives to crisis investment in a crisis cafe, and that was operational since June this year. Creative Solutions on London Road, and it's open 7 evenings a week. Adult community serious mental illness services. We've developed community mental health transformation developments in the first wave of developments. A service that's established ahead of all other Cheshire and Mersey services based on progress and early evidence is an exemplar nationally. Early intervention in psychosis, investment has increased, now in the top performing in terms of timely access and recording of outcomes. Perinatal mental health service was established and is receiving increasing numbers of referrals. Local data is suggesting that the service has delivered over 3,299 appointments just to Liverpool CCG patients alone. And we've also invested locally in our IAP services, offering recovery and waiting time targets are regularly met, and also access is expanding. COVID staff support hub. Obviously, in terms of COVID, we've been considering the health and well-being of our staff during the pandemic. It's put huge challenges and a need for their own health and well-being to be managed. And we put a healthline in across Cheshire and Merseyside. And we've also identified some more work to be done with rough sleepers, and Liverpool has been chosen as an early investor in those areas. So we've seen significant increases in funding. It's also required increases in staffing, and staffing across all services, including general practice, as Fiona has already mentioned, is one of our biggest constraints. If we could get more staff, if there were more qualified staff easily available, ready to be appointed, we could also make investments in other areas as well. But we do continue to invest heavily in mental health. We recognise the need. We know it's not enough, but we will continue to invest in these services. Thanks, Fiona.
Thank you, Jan. The third question is about loneliness. It says, combating loneliness is a necessary action to prevent poor health in all ages. And goes on to say that the questioner provides local events. So having been a healthcare professional in the past, now provides support in her local or his or her local community, and is wondering whether the CCG would ever consider taking on ex-healthcare professionals to help with well-being in the heart of communities. And the answer to that is that it's absolutely true that loneliness is a massive social issue and a health issue as well. It's linked to physical health conditions. And it is something that's much broader than what health professionals alone are able to solve. The CCG has invested into a social prescribing model of care over recent years, and all GPs are able to refer directly to a link worker who is connected into the local community groups that provide a holistic approach to health and well-being, and can connect patients to those groups in their local community that help them to combat that loneliness. And so if anybody is running a service informally, if you go to wellbeingliverpool.co.uk, you can see a bit more about what's going on, and we can put you in touch with your the local link workers so that we can connect you with people in your local community who would benefit from the brilliant work that you're doing as a volunteer. So thank you for that. The fourth question is Liverpool City Region's digital strategy report reveals that there are about 300,000 older or disabled people across the region who are digitally excluded, and as a result often suffer health inequalities or are denied vital health information to help with their well-being. The questioner is involved with the free newspaper which is called beg your pardon, so the Health and Equality newspaper that targets forgotten and overlooked sector of the community. I'm just wondering if the CCG will be able to work with them again in the future. Jan, comments on the digital strategy, would that be you?
Yeah, absolutely. And we recognise that, you know, the learning that we've got from working with communities, both from a testing point of view and also vaccination point of view, is, I think, even we were surprised at the ability for people to be able to engage digitally online or through mobile phones. You know, the testing solution we were given nationally was very much based on being able to book an appointment. And many people were just not able to access the national service because they weren't online or they didn't have a digital phone that they could actually receive the appointment details on. So that meant we just had to learn very quickly how we could engage more effectively with those communities that were not online or were not digitally enabled. And we do find solutions to that, and we do work around it. So we do recognise the scale, I think, of the challenge, and our digital strategies moving forward have to recognise the fact that those communities are excluded. And if we are to reduce inequalities, we have to find different ways to be able to accommodate everyone in any service or any strategy that we roll forward in the future. So there is a huge amount of learning. It's something that is very much a learning message from the experience we've had in testing and vaccination, and will help inform our strategies going forward. And obviously working alongside the City Council, this is part of the city plan agenda as well, in ensuring that communities are enabled to participate in this way, or we find alternative solutions to ensure that nobody is excluded going forward. But any comments or any thoughts or any advice, obviously we want to listen to our communities as well, so that we can take strategies and plans forward in a way that meets our needs.
Thanks, Jan. I think the next question is one for you to answer as well. How can the CCG help to ensure that the financial cuts and rationing of services and treatments, which will undoubtedly accelerate if the Health and Care Bill becomes law, do not disproportionately affect people who are already disadvantaged?
Yeah, a difficult one. I think the fair answer is I don't know. It's hard to predict with the bill still going through Parliament. We don't know what further changes will be made to that strategy. The CCG will not exist from the 1st of April. So there won't be an easy, straightforward comparison to what we've got now to what we will get in the future, because the money will come from NHS England directly to the ICS, and then it will be distributed on the basis of what is delegated to place-based arrangements. So assuming we continue to commission and provide services in the same way in Liverpool from the 1st of April, we would anticipate that we will get something similar to the sorts of allocations we've got now. If we don't have delegated some of the services that we've got delegated now, it will look very different. So it's impossible to say for any certainty what that kind of budgetary arrangement or financial arrangement is going to look like. I'm not convinced there will be significant cuts to NHS budgets. They seem to be increasing. Recent government announcements were significant billions being invested both in NHS services, with a commitment to that filtering into social care in the future. We need to see the detail of that. And year on year, we have seen increases in NHS budgets to meet the demand, and particularly to try and address the backlog of patients waiting for urgent care, emergency and planned care. So I don't see it as too negative. Hopefully with the integration that is being planned at local level in place with One Liverpool strategy and the city plan, we should be, reasonably okay in terms of expectations of what we've got now flowing in a similar way to Liverpool. And I know that as a city and as a very competent place, we will be arguing obviously for the fair and allocation to Liverpool to meet the needs of our local population. But, we will have to wait to see what transpires with the development of ICSs moving forward.
Yeah, it's a bit of an uncertain time, isn't it?
It is.
Thank you, Jan. So our final question, I think, let me just double check. Yeah. So the final question that we've received is, what is Liverpool CCG's plan for rolling out the COVID vaccine booster, particularly in terms of prioritisation of the elderly and vulnerable? So I've written out a really comprehensive answer to this, and I've just realised I've popped it in the shredding earlier on by accident. But fortunately, I think I know. So I have been working as clinical lead for Liverpool's vaccination programme for the last 6 months, a bit more now, and so I think I do know the answer anyway. So we've actually already started our booster campaign in terms of planning, and I know some patients have already had their booster, so that would be the people who were done very early on in the programme. Because it does have to be 26 weeks after your second dose before you have your booster dose. So we will be running our programme very much in the same way as we ran our previous programme at the start, but more slickly, because we are much more familiar with it, and we've got our sites are very used to running, and we've got really good at our systems and processes. We're really lucky in Liverpool that, again, our primary care teams have really stepped up here. We have 14 local vaccination sites being run by our primary care teams in Liverpool, which is significantly more than many other parts of the country and the surrounding area. So 14 local vaccination sites with 2 hospital hubs. So our hospital colleagues have been absolutely amazing in supporting us in this programme. We have Aintree Hospital site and we have the Peterhead site. We also have a range of pop-ups and pop-ups in practices and in community venues, which again, it is our primary care teams that have delivered this. And we have our vaccination bus. So it'll be a combination of those things, those offers that we will use to do the vast majority of the boosters. We will, however, be starting with the care homes and the very elderly. There is a target for us to have completed their boosters by the 1st of November, but I'm quite optimistic that in Liverpool we'll be able to do that ahead of target, because I know the practice teams are already working on these plans, and we're meeting with them regularly. We've also commissioned a specific team from Merseycare, who, again, our community providers have really stepped up to help us with the vaccination programme. So we have a special roving vaccination team to support housebound patients, vulnerable patients, learning disability patients, etc. And so anyone who would find it difficult to access our mainstream vaccination site offers. And so they are working on their plans and will be starting any day now. Like I say, some of them have already started. So people will start to see more media information about booking their booster doses, again 26 weeks after your second dose, and practices will be sending out text messages, and there will be letters coming out explaining how you can book your booster jab. And please do get your booster jab. And if there's anybody listening who hasn't had their first or second doses, it is never too late. Our practices and all of our vaccination sites are still offering first and second doses. So if you haven't had your first or second doses, please come along and get in touch with your GP practice, and they'll tell you where you can get your vaccine. Really, really important take-home message. Thank you.
I think we'd also add to that is to get your flu jab too, if you're in an eligible cohort. So it's, there'll be a lot of jabbing going on, so we need to encourage more and more people to take up the offer.
Yeah, more important than ever before this year, I think, to get the flu jab. It may be the case that some practices will be doing COVID vaccination and flu vaccination at the same time, so one in each arm when you come along. That would be great and really efficient if we could do it like that. You may have seen in the media that there has been some delays with the delivery of flu vaccinations, and so we decided that we weren't necessarily going to wait before we started the COVID booster campaign, because we do know that immunity is waning. We want to get ahead of the winter. So yeah, get your COVID and your flu jabs, please. Anything, Jan or Mark or Jane, that you want to add before we finish up?
No, I don't think so. But if there's any further questions that didn't get through to us before the AGM that have arisen following the presentations today, then please do get in touch, because they do help us. They help inform us the sorts of questions that the public have got about the services we offer. So please feel free.
Thank you. Is there a slide at the end that's got the email? Yes, there we go. So that tells you how you can watch back if you want to watch this again, or share or direct anybody else to watch and have a little look at the work that's been done over the last year, and the email address for any further questions. We will put responses to the questions that we've answered today on our website as well. So anything from Mark or Jane? No, you're all good. Thank you very much. Thank you for your work today, team. That was good, and thank you very much to our comms team. We won't judge based on the technical glitches. It's quite obvious that you've put a lot of hard work into preparing for today's AGM, so thank you for that. Thank you to everyone for joining us today and for sending in questions, and a big thank you to everyone who works in the NHS over the last 12 months for supporting us, for keeping us safe, and look after yourselves as well. Thank you. Have a good afternoon.